Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Hello, everybody. So today, as Hillary mentioned, we're talking about low-level viremia. I have no disclosures. This is the disclaimer. And we're going right into the case. I don't even have an outline because it's such a brief topic, and we're really going to talk about this case, and then we'll mostly discuss low-level viremia, what it is, and its management. So I wanted to frame with this patient of mine, who's a 60-year-old man with HIV, whose last CD4 count was 478 and viral load was 80, who also has multiple medical problems. I mean, he's seen for routine follow-up. I actually inherited him from a provider who left. I met him and saw that he has been taking TAF, FTC, dolutegravir, Maraviroc, and boosted darunavir twice daily since 2016. So a pretty hefty regimen because he has this genotype. He has an M184V, 2 TAMs, pretty significant NNRTI resistance, and a PI mutation. And as a little bit of a cheat sheet, since I'm not pulling up Stanford, you'll see here that, again, he has decent NRTI resistance to most all NNRTIs, and low-level resistance to darunavir. So this is the first time I'm meeting him. And I decide when I see his viral load of 80, and I see that this isn't the first time, I decide to kind of ask him my adherence review system. Some of you have seen how I kind of sort of separate out the questions I ask. So first I get to ask about dosing. I always ask, when was the last time you missed a dose? He tells me never, or, a very long time ago. And then I follow that up with, in the past week or month, how many doses did you miss? And this patient says no. Typically, I will also ask about white coat adherence, where patients will not take ART and then just take it for, a couple of days or a week before coming in to see the doctor. That's not what is going on, and he doesn't have a stockpile. And so you all know this is a patient that has an Excel spreadsheet with all of his medications and sends that to me every time that he needs refills. So he's quite fastidious. I ask him then logistical questions. What's your system for taking pills? How do you take your ART? Do you take it with food? And because of the darunavir, he says, yes, I am taking it with food. And he takes all of his pills together. Some people will split them up, but he's taking everything together. Beyond his medication list, I'm looking into drug-drug interactions. What over-the-counter meds do you take? Do you take any vitamins or supplements? And everything is on the Excel spreadsheet. This patient does have polypharmacy, but beyond that, he's not taking anything that I'm not aware of that could potentially interact with his ART. And then I ask him how he feels about his ART. Does he have any issues or annoyances with the ART? And he says no. This patient is very forthcoming. He's had HIV since the 90s. He says that he has polypharmacy. He takes 20 plus meds for many other medical problems. And he's like, what's, this many more? He takes all of them. So that's how he feels. But this is kind of a general framework when I'm asking people about their adherence. And I look back in EPIC and mention too that this viral load of 80 wasn't the first time that he had an elevated viral load, or a viral load that was not undetectable. And on the x-axis, we'll have the date, the month, and the year. And then on the y-axis is HIV RNA, which I have capped at 140. And so you'll see that he really kind of just hangs out always above 40, which is what our assay tells us, and has been in this general range. So we have an audience response question. What would you do with his ART in the setting of his persistent low-level viremia? Would you continue his current regimen, which, as a reminder, is Descovy, dolutegravir, Maraviroc, and boosted darunavir, which he had been prescribed twice daily? Would you add fostemsavir, which is actually what he asked me? Would you double the dolutegravir dose, or would you add doravirine? And there's no right answer. Like this is murky territory when it comes to management of low-level viremia. We can probably, perfect, close the poll. Okay, so 87% of people would continue the current regimen, which is what I opted to do. Some people would add fostemsavir, and some people would double the dolutegravir dose. So let's talk a little bit more about low-level viremia. I wanted to start off with some definitions, and these are some terms related to virologic response. We'll talk about incomplete virologic response, virologic blips, which I know many of you have seen, virologic rebound, and low-level viremia. So an incomplete virologic response is the failure to suppress HIV RNA to an undetectable level after 24 weeks of an ARV regimen. So just never kind of got down to undetectable. A virologic blip is after achieving virologic suppression, a single detectable HIV RNA level, usually less than 200, followed by a return to suppression. I know this has come up in echo before, and I think in my experience with patients, it's oftentimes, due to maybe they were taking it with a divalent cation or something like that. I know that some assays can differ between labs as well, and so I know that has come up on echo, so that is something that is a possibility, and I think a lot of us see blips, but not as many of us have to deal with this persistent low-level viremia. Virologic rebound is confirmed HIV RNA greater than 200 after achieving virologic suppression on ART, and what we will be discussing further today is low-level viremia, which is defined as persistent viral load or HIV RNA levels above the level of detection for the assay, but often less than 200 copies per milliliter, i.e. usually 50 to 199. And I recognize that every lab is different. I know some labs have a cutoff of 20, ours is 40, as I've mentioned. I've seen other labs with 50 and other labs with a viral load of 60. And some of you, in perhaps looking into the literature about low-level viremia, may notice that especially from countries outside of the United States or Europe, that you might notice that people have used higher viral load cutoffs. There are some older papers with a viral load less than 1,000 or viral load less than 400. But for the purposes of today, we are talking really about this persistent viral load less than 200. So possible etiologies of low-level viremia include suboptimal adherence, drug interactions, drug-food interactions, early virologic failure, right? We don't know what the trajectory of that viral load is, or none of the above. And low-level viremia, as we mentioned, is rare. Specifically in this pretty recent cohort from 2022 of about 1,500 persons with HIV from Taiwan who actually switched to dolutegravir or bictegravir, the incidence ranged anywhere from 1.2 to 1.7%. Some older data will show that the incidence can be 7% or even higher, but in general, this is pretty rare. And I would say this kind of makes sense in this less than 5% of patients, at least that I've seen, tend to have this persistent low-level viremia. And in the setting of excellent adherence to a potent ARV regimen, it is felt to be due either to replication-incompetent HIV being released from a latent reservoir or potentially also just persistent replication of HIV. And the data about low-level viremia is mostly conflicting, which is probably why there isn't great guidance on exactly what to do. So as far as mortality goes, some data show no association between low-level viremia and increased mortality. And you'll notice that first citation is from 2014. There they actually looked at viral loads less than 400, and they found there was no increased mortality. But in a more recent 2020 paper, they found that low-level viremia was associated with increased mortality. And so this you will notice when you look at the literature is all over the place. And every year there's a couple of papers that come out, and some suggest this and some don't. And I think my takeaway is that in general, I tend to see more papers just from a volume standpoint that are associated with that show increased mortality. And I guess I'm not surprised that if someone has a higher viral load, that this is plausible. The next kind of big question about low-level viremia and its impact is, what about virologic failure? So in a 2019 paper, they found that it was associated with virologic failure with an adjusted hazard ratio of 1.83. This Taiwan cohort that I had mentioned to you earlier, they found that there was no increased risk of virologic failure in those with low-level viremia while on dolutegravir or bictegravir. So while I'm talking, you might be getting confused because I'm telling you that some papers say this is the case and others don't, but also when reading these things, wonder what regimens are these individuals on, and really how prevalent is low-level viremia, especially in the INSTI era when many of us are using dolutegravir and bictegravir. And so in that cohort, there was no increased risk of virologic failure. And then in about September, a paper came out from a European cohort from Elfstam and others, who also has published several times about low-level viremia before, and as you might notice in the citations, in 2020. And this was a pretty big paper where they looked at about 22,000 individuals and found of that 22,000, 7% had low-level viremia. This was a pretty long study over maybe 15 years. And so about 1,600 people had low-level viremia. And they found with a viral load less than 200 that low-level viremia was indeed associated with virologic failure with an adjusted hazard ratio of 2.2. So this is a pretty recent paper and a pretty large paper from Europe. So pretty generalizable to America, at least with a viral load less than 200. And then they also they did a sub-analysis looking after 2014 and found that this was still the case, that it was associated with virologic failure. So again, that's an era in which dolutegravir was around. But I was still curious. So in supplemental table 8, they did a sub-analysis looking at INSTI-based initial regimens, and they found indeed that low-level viremia was not associated with virologic failure, so kind of similar to the Taiwan cohort. So the next question I think many of us will have is, okay, if someone is persisting at this viral load of 50 to 200, how does that impact drug resistance? So in that European cohort that I just mentioned, this most recent paper, mutations are commented upon. And they'll say, oh, there were a few drug resistance mutations that were found, and actually a fair amount found. But in supplemental table 9, very deep within the supplements in their last table, you'll find that they actually only found mutations in people with a viral load 200 to 999. So not exactly applicable to this patient and really our question, which is what happens in persistent low-level viremia. Perhaps a little bit more pertinent to this question is this paper from 2020 of a Chilean cohort of 16 persons with HIV on INSTI-based regimens and in this paper it was a viral load 22 to 175. They looked at proviral DNA and they found some resistance-associated mutations, but it was unclear if these were transmitted or not, because in none of these 16 patients did we actually have any baseline genotypic data. So it's really hard to know, was this transmitted or not? There was one patient who had only ever been on Triamec, who had viral loads in the 50 to 80 range, and they had an E138K integrase mutation, but that's it. Otherwise, I saw this paper, I thought, okay, this might kind of answer our question, but not exactly, because usually we have genotypes and I didn't know if these were transmitted or not. So the big takeaway about the drug resistance thing is that most studies have shown a low risk of virologic resistance in persons with a persistently detectable viral load less than 200. A big important part about what to do about the low-level viremia, especially because it causes us to fret so much and likely also causes the patients to worry, is that we shouldn't forget the concept of U equals U, which we think we all know is about how an individual with an undetectable viral load cannot transmit HIV to their sexual partners. This is based on data from the HP2N052, the Partner 1 and the Partner 2 studies. And I'd really like to hone in on the Partner 2 study, which I know most of us know, but as a reminder, this was a study in which they looked at 972 serodiscordant coupled men who have sex with men who had had 76,000 acts of condomless anal sex, and there were no HIV infections phylogenetically linked within couples. And what they defined as undetectable in that study was a viral load less than 200. Thus, I think for the vast majority of our patients with persistent low-level viremia, though everyone is stressing about this, we don't necessarily have to worry about transmission. I always wonder too, well, okay, they're less than 200, but have they bopped up to above 200? We check every couple of months, every 3 months, in fact, if someone has low-level viremia, and I just haven't seen people, unless they're failing, bop as high or above 200. They have tended to stay below 200. And so the DHHS here on the left states that patients with low-level viremia do not typically require a change in treatment. Although there is no consensus on how to manage these patients, the risk that drug resistance will emerge is believed to be relatively low. Therefore, these patients should continue their current regimens and have their viral load checked every 3 months. Similarly, the IAS USA guidelines state that for patients with intermittent or persistent low-level viremia between 50 to 200, assessments for ART adherence, tolerability, and toxic effects are recommended, but changing ART is not recommended unless ART toxicity or intolerability are identified. And additional comments that I've added here on the management of low-level viremia is that we should not be doubling the dose of a medication or adding another medication. One of the options I offered in the ARS or the poll was to double the dolutegravir dose. In fact, in 2010, Dr. Gandhi looked at doubling raltegravir in people with low-level viremia, and it didn't help. So thus, I extrapolate from that, and I'm not doubling the dolutegravir, and I'm not adding another medication because we just don't have data that helps. If you see this number, don't stop ART, please continue ART. And then as we kind of already talked about, assess adherence, ask exactly how the patient takes their medications and assess drug interactions, food requirements, and absorption. If on an ART regimen with a low barrier to resistance, update their ART, certainly, but otherwise changing or intensifying ART is not recommended. And some people might consider obtaining a darunavir level. I thought about this in this patient, but he was, again, very adherent to his meds. Perhaps he had something going on that would affect his darunavir absorption. He took it with food, and I discussed it with the patient that this was an option, and I kind of felt that it would help me, maybe more than him, but I wonder, and I know some people might check it, and again, there's no right or wrong with regards to that. I was going to ask this question again, but I actually would opt that we continue because we're almost done, because 87% of you suggested continuing the current regimen. And again, there's no right or wrong here, but that is what I did. To tell you the rest about his story, he eventually, first off, we're not even sure he needed BID darunavir with just one darunavir-based mutation. He might have been fine with just one, with DRV once daily with the booster, but I didn't feel comfortable simplifying anything when somebody had low-level viremia. I continued him as such. Eventually, he developed cardiac disease and had hyperlipidemia, and so I actually took him off of the darunavir, put him on fostemsavir because of the hyperlipidemia and heart disease, and then he suppressed. I was more excited about this than he was. I was so thrilled. And he's like, Jehan, sometimes your viral load is just going to do what it's going to do, which I thought was actually quite poignant. So with that, to wrap up, key points, low-level viremia is defined as a persistent viral load level above the level of detection for the assay, but below 200. To assess adherence, ask how the patient takes meds, assess drug interactions, food requirements, and absorption. We've already talked about this. That low-level viremia may or may not increase risk of virologic failure and or mortality, though maybe might actually. And then if on an ART regimen with a low barrier resistance, as I mentioned, update it, but otherwise, no need to change your meds. And lastly, in 2017, so a bit dated, but Dr. Paul Sachs, who has the New England Journal blog, wrote, regardless, the absolute risk of failure is still quite low, especially if adherence is good, and patients do not appear to be slowly developing resistance to their regimens. So I would love to open it up, because I know that there's a lot of this that is actually sort of stylistic, and so would love to hear what people have to say.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.